Welcome back, students, to Decode Healthcare with Harshal. Today, we are diving into Part 121 of our masterclass. Now, in Part 120, we covered MDC 23, focusing on surgical procedures for factors influencing health status in donors. Today, we're shifting gears to an advanced MSDRG deep dive into the architecture of inpatient coding, looking specifically at how the system handles some of our most complex, high-acuity patients, multiple significant trauma. Before we get started, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal.
Here is our syllabus for today's Elite Masterclass. We're going to cover 4 main areas. First, MSDRG architecture and trauma. Second, the massive financial power of CCs and MCCs. Third, we'll look at complex cases and ventilation. And finally, we'll wrap up with clinical documentation integrity.
All right, let's jump right into Section 1, MSDRG architecture and trauma.
So, you probably already know that the Major Diagnostic Category, or MDC, is the absolute highest level of DRG classification, and it's driven entirely by the principal diagnosis. Usually, these MDCs correspond to just a single major organ system, but trauma is different. When a patient sustains multiple significant traumas across distinct anatomical sites, the system's architecture actually bypasses that single organ logic. Instead, it triggers a specialized category, MDC 26, which is reserved exclusively for these severe polytrauma scenarios.
So how exactly does the DRG grouper logic engine figure all this out and assign the final tier? Well, it's a very strict step-by-step sequence. Step 1. It identifies the principal diagnosis, which locks in your base DRG family. Step 2. It scans the secondary diagnoses to check for any complications or comorbidities. Step 3. It looks for major operating room procedures, because as we know, a major procedure immediately shifts the patient from a medical DRG over to a surgical one. And finally, Step 4. It adjusts for demographics, things like age, sex, and discharge disposition, before spitting out that final MSDRG.
Moving right along to Section 2, the power of CC and MCCs. This is where severity adjustments really come into play.
You'll notice that almost every MSDRG is broken down into a triplet structure. It's kind of like a 3-tiered ladder. At the very bottom, you have your cases without any CC or MCC flags. Naturally, that yields the lowest payment. Step up to the middle tier, and you need at least one complication or comorbidity, a CC. That flag increases the severity, bumps up the expected resource use, and gets you that middle payment tier. But the top tier, that requires an MCC, a major complication or comorbidity. Capturing just one MCC flag means you're dealing with a highly complex patient requiring a ton of resources, and therefore it unlocks the absolute highest payment tier.
Under CMS rules, these severity adjustments make clinical documentation absolutely critical. A vague diagnosis might just land your patient right down in that base tier, but if you have specific, highly accurate documentation, say explicitly identifying septic shock instead of just writing localized infection, boom, that flags an MCC and completely transforms how the case groups.
And this brings us to the math, the massive financial stakes behind this formula. Hospital payment equals the base rate multiplied by the DRG relative weight. The base rate is just a fixed dollar amount set by CMS, but that relative weight, that reflects the true resource intensity of the specific DRG. So a higher relative weight from an MCC directly multiplies your hospital's base rate. Think about it. If your base rate is $6,000, an MCC that pushes the weight from 1.0 up to 1.3 means an instant significant jump in reimbursement. Capturing MCCs accurately isn't just a coding exercise, guys. It is literally fundamental to the financial survival of the facility.
All right, Section 3, complex cases and ventilation. Let's look at some high acuity scenarios.
Mechanical ventilation has some incredibly strict coding rules. The clock starts at the exact moment of intubation, and it stops right at extubation. Coders have to categorize this duration meticulously. Is it less than 24 hours, 24 to 96 hours, or is it greater than 96 hours? Why is this so crucial? Because crossing that 96-hour threshold is a massive trigger in the MSDRG coupling logic. For instance, if you couple acute respiratory failure with mechanical ventilation that goes over 96 hours, it very often triggers an MCC, which, as we just discussed, dramatically increases the DRG weight.
Now, in multiple trauma cases, tracking neurological severity is paramount. We often use the Glasgow Coma Scale, or GCS, but here's the catch. You can't just code a GCS on just anyone. The rules strictly dictate that it's only coded for specific conditions: traumatic head injury, intracerebral hemorrhage, subdural hemorrhage, or subarachnoid hemorrhage. Interestingly enough, GCS is actually one of the very few items that coders can pull from non-physician documentation, like nursing flow sheets. This makes it a really vital tool for painting an accurate clinical picture during chaotic trauma resuscitations.
Another highly complex, very common scenario in trauma is sepsis. The sequencing rules here are absolute. If your patient comes in with a localized infection and sepsis is present on admission, sepsis takes the top spot as the principal diagnosis. But what if a trauma patient develops sepsis later during their hospital stay? Well, since it's a complication of care, it has to be sequenced as a secondary diagnosis with a present on admission indicator of N. If you get this sequencing wrong, it completely skews your DRG assignment and acts like a magnet for payer audits.
Which leads us perfectly into Section 4, Clinical Documentation Integrity, our absolute best defense for revenue integrity. As the quote says, accurate and specific clinical documentation is the lifeblood of the IPDRG system. It's so true. If the clinical picture drawn by the provider is vague, like if they just scribble heart failure instead of spelling out acute on chronic systolic heart failure, coders have their hands tied. They're basically forced to default to a less severe, lower-paying DRG, or they have to hit the brakes on the entire billing process just to issue a query.
And when CDI specialists do have to issue a query, compliance is absolutely everything. Let me give you an example. A leading query that asks, "Doctor, the hemoglobin is 6.2, can we code acute blood loss anemia?" is totally unacceptable. It biases the provider, and it's a huge audit risk. On the flip side, a compliant, non-leading query just presents the clinical facts objectively. "Doctor, the hemoglobin is 6.2. Can you clarify if the anemia is acute, chronic, or due to another cause?" See the difference? You're asking for clarification without spoon-feeding them the answer. In the real world, CDI specialists are constantly stepping in to close these kinds of documentation gaps. Maybe it's clarifying an ambiguous diagnosis, like changing history of stroke to history of cerebral infarction due to embolism. Or maybe it's nailing down the severity of acute respiratory failure. These compliant queries bridge those gaps, ensuring the medical record supports the highest, most accurate DRG. And to be clear, that is true compliant coding. It is absolutely not upcoding.
A massive piece of the CDI puzzle is capturing the POA, or present on admission indicator. POA is defined as a condition present at the exact time the order for inpatient admission occurs. This is the only way to distinguish a pre-existing trauma from a hospital-acquired condition, or HAC. If a patient arrives with a stage 3 pressure ulcer, it's POA. But if they develop a stage 4 ulcer while lying in your ICU, that's hospital-acquired, and it fundamentally changes the payment logic.
CMS tracks this using specific indicators. Y for yes, it was present. N for no, it wasn't. U for unknown due to insufficient documentation, and W if it's clinically undetermined. This is a big deal, guys. If an MCC has a POA indicator of N, meaning it developed after the patient was admitted, like a deep vein thrombosis, CMS will very often flag it for quality review, and that usually comes with a non-payment penalty for that specific complication.
All right, let's bring it all together in Section 5, Summary and Next Steps.
Let's do a quick masterclass recap. First, MDC 26 is our unique category for capturing multiple significant traumas across distinct body sites. Second, secondary diagnoses, specifically those CCs and MCCs, are the engine driving your DRG relative weight. Third, mechanical ventilation requires strict, down-to-the-minute timing because hitting that 96-hour mark changes everything. And finally, CDI queries must absolutely remain compliant and non-leading if you want to survive a payer audit. So I want to leave you with a provocative question to consider regarding your own facility. Are your hospital CDI queries truly compliant, or are they inadvertently leading providers and risking massive audit denials down the line? I highly recommend taking a hard look at your internal query templates after today's lesson.
Well, that brings us to the end of today's explainer. Up next, Part 122, Advanced Surgical DRG Deep Dive, where we'll look at the surgical side of multiple significant trauma. If you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal.